My name is Ed Cantwell. I'm Senior Vice President at the West Health Institute, and it's my honor to welcome you and welcome our panelists. And the focus of this panel is going to be driven by what you heard this morning. Who was in the keynote this morning? Connected and shared, right? Connected and shared. Two assumptions that are being made that maybe aren't necessarily a reality yet today. So we have assembled a panel that represents, in essence, from soup to nuts, the infrastructure or the ecosystem that would be required to make connected and shared a reality. Right? So the theme of this is going to be, can we get through the entire ecosystem, and what does it take to be connected and shared? And ironically, if I could take a little bit out of each of these four gentlemen, we'd have the perfect healthcare system, right? So let's hope they don't collude and go form one. So let me introduce the panel. First of all, Dave Duncan, to the far left, is Corporate Vice President of Facilities and Support Services at Health Alliance Hospital outside of Boston. He owns, as the head of facility engineering, biomedical, materials management, dietary, environmental services, child development center, and security. In other words, just about anything that goes on requires him. He's also one of the rare, 6, 7, 8 year veteran of deploying wireless in a really profound way. Paul Peabody, second to the left, is the CIO of Palomar Pomerado Health System, who just opened what is considered arguably to be the hospital of the future in Southern California. Previous to that, he was a leader with Oracle in their healthcare business unit. And prior to that, spent 30 years as the Vice President CIO at Beaumont Hospital in Michigan, claim to fame, one of the first to deploy electronic medical records. So a tremendous amount of wisdom. Dr. Sloan is just a veteran of about everything, 40 years in dual career of IT and clinical engineering. He's been a CIO, COO, CTO, CRO. What's a CRO?
Chief Regulatory Officer.
Oh, okay.
Get to meet the nice FDA people.
He's the current president of CHIRP and really is a domain expert on for the government, healthcare IT, and really is engaged helping the Institute tackle things like interoperability, privacy, and security. And then lastly, Dr. Bill Gregg, to my left, is from Vanderbilt and is a general internist and a member of the faculty for Vanderbilt's Biomedical Informatics and Medicine. He leads, or he's very involved in how they go after health promotion and disease management with mHealth. It's mHealth Vanderbilt.
mHealth team.
Yeah, mHealth team at Vanderbilt. If you've not looked at the website, you should. And he really brings the perspective of what do you do with the data. So if you build a hospital, you put wireless things in it. The devices are secure. What do you do with it? So the theme here is let's talk about what I call the platform for wireless health. Whether you call it the connected health infrastructure or mobile health or wireless health, it's it's what the infrastructure needs to do in order to produce this environment of ubiquity. So what I'm going to do is I'm going to ask a series of questions, the 2 rounds of questions, but since we're such a small, intimate group, I would encourage a very interactive session. So let me first start by teeing up a question for Dave Duncan. And I'll tee it off by saying, in my opinion, wireless has become the next expected utility inside of a building. You wouldn't think about building a hospital without plumbing or electricity or heated and cooled air. But you'd be amazed at how many buildings are being built without making sure that wireless works as a utility. So Dave, as the head of facility, what's your view on this concept of wireless as a base building facility like plumbing, air conditioning, heated and cooled air? And what is the role of the facility leader in making sure that that utility is made available? And if you do it, do you see any cost savings, improved quality of care?
Thank you, Ed. I agree with you. Today, you don't build a building without a building or your home without a water line, a sewer line, electricity, heat, and air conditioning. And today, there's so many healthcare buildings built without a wireless, an engineered wireless infrastructure. It's a standard. It should be a standard. And if you do build a building without an engineered wireless infrastructure, then it's going to end up being a modified system once the building opens. We all have been in an office that wasn't suited for the use now, and the heat doesn't work or the cooling doesn't work. So in today's environment, I think, and I ask you all to challenge all your facilities people as you modify, renovate, build something new. How are you going to install wireless infrastructure that is like a utility? Some advantages, some efficiencies, some improvement in quality. Quality of care can be summed into many, many different things, one of them being just good communication and not broken communication. And when you have an engineered wireless antenna that everything can tie into, that there is no dead spots or no spots where the cell phone doesn't work or the telemetry doesn't work or the wireless IV pumps don't work or the wireless EKG system doesn't work, then you can improve quality of care because there's not miss or lost communication. From an efficiency point of view, cost savings and efficiency is when you have great communication that is not broken, boy, your efficiency will be much quicker and much more improved. When physicians, primary care internists can speak instantly and without any interruption with specialists, you'll get improved quickness of care, which results in improved quality of care. So those are some quick examples.
Okay, thanks. So moving on, Paul Peabody got to, I guess, experience the process of opening up a brand new, very large hospital, and as the CIO was the spearhead over what wireless services were deployed. But the question for Paul is, given you have a world-class facility guy like Dave, is what role does wireless play in changing workflow inside the hospital? And how could a connected and shared environment actually improve workflows?
Sure, Ed. I have a great example of that. But first, let me just give you a little background on the hospital because it's important to know that this is not this isn't the greatest hospital in the world that you're going to find in terms of technology. But we're using the technology very well to support the design concepts of the hospital. We built a facility that's a 300-bed hospital, can be easily expanded to 600, 650, quite a bit of shell space as well. And we worked with the Center for Healthcare Design in terms of building this facility. It could be LEED certified. It's not, but it's built to those standards. So it's a very green facility. But the Center for Healthcare Design utilized evidence-based design concepts, something that was developed in Dartmouth in about 1998. There are 14 Fable hospital concepts that some hospitals across the country that have been built in the last 10 years or so incorporate. At our facility, we incorporated almost all of them. Now, to tell you what they are, if I give you an example, a couple of examples, they're very large patient rooms that are all same-handed. Very large bathroom facilities with double-wide doors and railings that lead from the beds in and around the bathroom facilities. There are no nursing stations at this new hospital, so the nurses and caregivers are positioned outside of the rooms. They can look into both rooms at the same time, and they're located in alcoves where they have their workstations or PCs typically are in those alcoves. And so no nursing stations in this facility. We built healing gardens. Now, we're in San Diego. We're not in Detroit or Chicago or Minneapolis. So we were able to build a glass cylinder, and if you would envision a glass cylinder going up the middle of the hospital that is open on the outside end of it, so that you can walk out in these gardens, sunlight, plants, a wonderful healing environment. And the evidence shows that patients that can get into these healing areas, they heal faster, they use less heavy medications. So that's an example of evidence-based design that we incorporated into the facility. So what about the technology? Well, just kind of the standard stuff. Because we were able to build from the ground floor up, we have a 10 gigabit wired backbone. We still need wired today because of images and some of the real heavy traffic, but we also have a very solid wireless 802.11 infrastructure throughout. And we also were able to build a distributed antenna system, a DAS, because we built it from the ground floor up, so that we could use that for cellular communications. So to your question, Ed, how have we used the technology in an advanced facility like this to support different workflow? Well, without nursing stations, we had to address the communication between caregivers. Now, certainly you're all familiar with the old nurse call system. You hit the button, and it goes to a central station located in a nursing station. Probably a unit secretary sees the alarm, the alert, and then they go try to find the caregiver. They try to find the nurse. They try to find the nursing assistant. Maybe they find them. Maybe they don't find them for 15, 20 minutes. Maybe they don't find them at all. And so the patients do not receive the service that they asked for. Plus, the service under the old system was one-dimensional. You didn't know what it was that they really wanted. Well, today, with our nurse call system, we have a Responder 5 Roland Borg nurse call system that has the scheduling profile for the nurses and those patients. So we know who the nurse is, we know who the backup nurse is, we know who the nursing assistant is, and we know who the charge nurse is that's associated with that particular patient. In the room, there is a pillow speaker that has buttons on it, and the patient will press that to ask for water. There's another button for pain medication. There's another button for assistance to the bathroom. And so based on that alert, and we have a middleware system, we're using extension middleware to be able to route the transactions. So request for water will go to the nursing assistant. A request for pain medication will go to the nurse. If the nurse doesn't respond to it, then the backup nurse will be alerted. If the backup nurse doesn't respond to it, then the charge nurse will be alerted. So the patient is getting the right service, and they're getting it promptly in most cases. We're finding improved patient satisfaction as a result of that. We've also integrated telemetry so that for certain thresholds, the nurse will be alerted in terms of from our telemetry system. We've also integrated our CPOE and our Cerner system so that when a physician orders a stat lab, that stat lab we will notify the nurse that a stat lab has been ordered so the nurse can follow up on it. We'll go the other way as well. We're not doing it today, but when a lab test hits certain thresholds or whatever the test is, we'll alert the physician as well through their smartphone, their smart device. We will also, we've just implemented Sotera Wireless. We're the first hospital in the country to demonstrate and to pilot the Sotera Wireless devices. These are wireless monitors that have just been FDA approved that will monitor vital signs, including blood pressure. And we'll be monitoring all of our patients so that when they go out in these healing gardens, we'll be able to know if they run into trouble, and we can alert the caregivers as well. So we are changing the workflow in terms of wireless technology, and we're using Cisco wireless phones that we send the alerts on. So we're changing workflow based on technology and based on that wireless infrastructure.
Thanks. So let's hit that pain button next to the pillow and talk to Elliot, who really has for years wrestled with device security and device management. And this is a huge, huge challenge as hospitals comprehend bring your own device. So Elliot, the question is, one, what expectations should we have that these thousands of devices are both secure and can be managed properly in this environment where Dave builds a great hospital and Paul fills it up with wireless devices?
Okay. So let's take the metaphor from earlier today and that you started with, Ed, which is we want to be in a connected and shared environment. And to start for a moment on the pain side, I look at it as how do we get from where we are, which is connected and scared, to connected and shared. There are a number of mechanisms at work, and we've looked at these through a lot of eras of medical technology innovation. It's hard to imagine a world where there weren't clean and well-organized operating rooms, emergency departments, and emergency physicians. There was a time when there was no such thing as an emergency physician. The emergency physician was whoever the radiologist or internist or surgeon happened to be on duty that evening or weekend. So among the things that we have to do, looking at some of the detail issues, sort of technical issues, we have to have seamless, ubiquitous wireless where there aren't coverage gaps, where we have very high reliability and confidence that there are no dropouts of life-critical messages. An alarm, a baby stopped breathing, someone is on the floor. We talked about the Sotera system, a wearable monitor, or a medication that's about to be administered that could be lethal for the patient. These are alarms and alerts. How do we make sure that in a wireless environment where patients may be wearing technologies and mobile in a healing garden, that this sentient hospital, this aware hospital, this nervous system of safety is being put in place and is always reliable? How do we deal with areas of infection control? One of the advantages of wireless, if you've ever been in an emergency room or operating room and you see all the wires and cables on the floor all day long, the patients come and go, and those cables and wires are still being stepped on and moved around and pushed around. We work so hard to keep a sterile field, and yet these cables are full of dirt and grit and not things that you would like to know about or want in your body. Another issue is this point of care, moment of care. The real time for decision is when the patient is having a problem, when the physician or caregiver is there. It's not useful to learn an hour later the patient has an allergy to a certain medication, or a particular medication has already been tried and that patient has not had any good benefit from it, where a lab result is available to tell you that that patient actually has a different disease than you're treating. So this moving the care to the point and moment of care is part of the opportunity that ubiquitous wireless is presenting. And then I heard you mention flexible space allocation. No, the fact is that hospitals ebb and flow through the year. You know, in flu season, they are overloaded with folks, and then in the summer when elective surgeries are down, they have a lot of extra space. The balance and need of space with wireless systems, you can have flexible, extensible systems to match the patient load, which you cannot do otherwise. So how do we get there? I mean, one of the classic ways of getting there is the Joint Commission and the surveying process of hospitals, and they have really rich guidelines for electricity and for gas and for water systems. In electricity alone, there's a hospital-grade plug, and there's specifications of what things have to be on backup power supplies, all sorts of tests around that. Also, certification of components. We know that a hospital-grade plug is designed to be a certain strength and capacity, and we also know that in terms of hospital-grade, that it has power requirements, a durability, and when it's bright red, we know that it's connected to a backup generator, so you can put a ventilator with life support equipment on it. How do we do that in wireless? We can do that, but we haven't gotten there yet. Those are standards in the environment. So when will this really happen? It's when the voice of the customer, the community, voices like yourselves who say, we have to have this. We have to have a certain minimum level of wireless capability with a certain minimum level of quality, reliability, safety to meet these needs, and we have to be able to buy it in a reasonably commercialized package and not build it ourselves with nuts and bolts and pieces.
Thank you. Well, on Thanksgiving Day, I welcomed my first grandson 2 months early, and in rural Kansas, and was immediately put in an ambulance and sent 2 hours away due to the development of his lungs. So, of course, my current job, you know a lot more about the system than you would prefer to know about it. But Dr. Gregg at Vanderbilt is really involved in probably some of the most profound I call it clinical decision support, and that is the ability to take the data and really do something with it, the right medication at the right time. So my question to him is, once you build a building that has a great CIO and the devices are secure, what do you do with the data, and how do you use the data to both lower the cost of healthcare and improve healthcare?
Thanks, Ed. I think that, one of the things that we approach this view of distributing data and using data for patient care at Vanderbilt is that the mechanism of delivery isn't as important in the beginning. The most important thing is the workflow, and we've got to be able to accommodate the workflow of the different clinicians involved. One of the things that we're really noticing is that the care team is expanding. So we use the mantra of everyone should work at the top of their license, and that includes the patient. So as we distribute our decision support and try to engage our patients more directly, we have to use whatever tools are available, but that's something that can improve over time as the technology evolves. So, one of the things that we've taken, and I want to emphasize what Elliot had brought up before, is the idea of point-of-care decision-making. When physicians and other clinicians try to make decisions in batch mode, and when in medical school we learned about that, is where you keep making long lists of all the things that you have to do, and then you eventually, whenever you stop taking care of the patients, you've got to go and do those things that are the product of what you've been what you've been gathering. It's ordering things, making those decisions. That is a deeply flawed method whenever you're trying to take care of patients in a very fast-paced environment. And I can tell you that both in the hospital and out of the hospital, making these things ubiquitously available has really started to change the way we care for patients. I just finished a rotation on the inpatient service, and when we go around on rounds, compared to when I was a resident, we used to make those checklists of all the things that we had to do. But now we sit and each of our residents is actually issued an iPad. And, the technology, the specific technology doesn't matter, but just the idea that we can have that. At bedside, we can both do the orders that we need to do, that we're deciding on for that particular patient, and know about their allergies, and know about the drug that's already been tried, but also to sit at the bedside and show the patient what their chest x-ray looks like. Those things can have a dramatic effect on the way, on the work that we're doing with our patients. When we move to the outpatient environment, it does become somewhat more complex, because the difference is that now not only is the patient separated in space, because they're not right in front of us, but things are also separated in time. So it has to happen over a much longer continuum, and that introduces a lot of issues. But it brings to the forefront the importance of engaging that patient and bringing that clinical decision support, so that we can say, you know, this is just as an example, we'll take our patients and we'll monitor a population of patients with hypertension and with diabetes and look and see what are the different levels of risk and when's the next time that we need to have a contact with that patient. Allowing that ubiquitous availability of data allows you to direct resources where they need to be. So unfortunately, right now, we direct resources in a completely random way. There are patients who get far more care than they need, and there are patients who don't get nearly the amount of care that they need. But if we can take, as a foundation, this technology and use the algorithms that we're going to learn over the next 10 and 20 years, and that people have already started to develop, and say, how can we allocate that resource, that contact with the patient, not just in the hospital, but out of the hospital? When do we need to call them? When do we need to have a telemedicine contact with that patient? And what's the most appropriate way to do it? So, you know, this idea of ubiquitous use of both the data and the technology is going to be critical if we're going to take things to that next level and understand how we can allocate those resources and do it effectively.
So, is there anybody in the audience from the carriers? AT&T, Verizon? Be truthful. So, since there's not, let's talk about them. It is amazing that it's assumed that connectivity is going to be there, and ubiquity is in the hands of two very large companies in the U.S., right? They own 90% market share. They provide a level of redundancy in certain cases, and with the adoption of LTE, we're now up to the global, standard, which will really drive costs down and increase capacity.
Tell that to those of us who are standing out in the courtyard all morning trying to make calls.
I tried to be nice, right? I'll ask that question of the audience. Do you think it is the obligation of AT&T and Verizon and Sprint and T-Mobile to provide ubiquity? No. Why?
Because it's like electricity. Raise the microphone. Thank you.
Are you from the carrier?
No.
Okay.
I'm a biomedical engineer, and I'm developing middleware for ubiquitous computing. I feel like it's like electricity, They provide a utility, they provide a source through which we can communicate, but we should have the independence to build our own customized applications and use AT&T, Verizon, or any other telecom company as a source of communication, as a roadway, rather than them trying to control everything on our behalf. The direction has to be set by professionals. They can only contribute and build an ecosystem around it.
So the real question was, do you expect the basic connectivity from our national carriers upon which to build your service and your application?
Not required. We shouldn't expect it, because how will that change? It's too much influence in the way a physician would want to, deliver his care, and you want the independence to stay away from, sticking to a particular company or a network provider.
So, Paul, a question for you. piggybacking on this discussion, what role is bring your own device? Does everybody understand what we mean by that? A doc's walk in the hospital
It accuses me of pain.
with their own device, right? What role is bring your own device going to play in the next 5 years at your hospital?
Well, huge. It's playing a role right now, and if I could continue on the example that I talked about earlier, the next step for us is that we want to be able to notify physicians of certain conditions. So abnormal test results, something is showing up on telemetry. We want to be able to notify them on their smartphone devices, wherever they are. But wherever they are includes when they're in the hospital. And right now, we can't do that because we don't have all of the carriers participating. We invested in a distributed antenna system, which we were able to do because we built the hospital from the ground floor up. So we put in our own distributed antenna system, and we asked all the providers to participate. I'll tell you, that's because there's no business case. You can't guarantee all 4 of them business. And in our case, I didn't guarantee any of them business. So I said, we want you to play. We want you to participate. It's good for you. It's good for your customers, patients, visitors, physicians that use your devices when they're in our facility. We got 3 out of the 4, and we will get the 4th one. AT&T will hook up in the next couple of weeks. So we have Verizon, AT&T, Sprint, and T-Mobile all participating on our distributed antenna system. What that allows us to do then is to be able to now use this alert management system and communication system we put in place to be able to go the other direction in terms of our physicians and notifications. So it's really important, but it was a huge struggle. It took, I was on the phone to them constantly. I think they hooked up just to make me go away.
It's not a bad tactic.
John Squayo from hospital entity, 28 hospitals nationwide, and I really appreciate all your comments. This is just right to hits on a lot of our pain points right now. And done distributed antenna systems, a lot of our hospitals introduced multi-carrier situations. I'd like to comment that I think the move from corporate liability to independent liability with our carriers when we did our BYOD across the company actually helped get more carriers plugged into our NAS. And the reason for that is with their new contribution models that they're running in finance, they're finding that as long as there's a customer base within our facility, whether it's we're committed or not, they're going to find a business case there. So the other major component that I've found that's a challenge with mobility to the docks is even though we have an integrated delivery network with employed docs, we have a huge amount of still affiliated and credentialed docs visiting our hospital, and it's like a land grab with mobile device management. So you got to get your MDM on there first, because if they're presenting at 3 other hospitals, you can only have one MDM. So if you're delivering critical results and you expect that to be secured by your policy, you got to be the first one on there, and then it's a juggle with the physician on where they put the most business cases and as such, which one they want to keep. And that's a major impediment to us right now. But
Thank you.
Ed Harry Greenspan from Deloitte. Quick question. We talked about physicians, and as a physician, I love talking about doctors. But what about the patients? I showed up at this conference expecting to have an app on my phone to tell me where this presentation was, where to go. Even at the hotel, I've got an app on my phone that will control the TV, so I don't have to touch the remote for obvious reasons. How much, I see Jeff here from Get Well Network, you see a lot of patient applications and the kind of that patients are involved in. How strong is the patient movement in terms of being able to communicate with each other, with their providers, with their families, impacting the kind of work that we see now?
Dr. Reddick, why don't you take that?
I think that's a great question, and and kind of going back to the idea that I talked about before about everybody on the team working at the top of their license and bringing the patient in. The issue that we run into, of course, is that there is no single ubiquitous technology among all of our patients. So no matter how much we want to, we have to adapt, and this is something we were talking about earlier, we have to adapt to whatever method of communication our patients want. Obviously, one of the ways that we've looked at it, obviously, is that there are certain methods of communication, for example, through our patient portal, that patients can access via wireless devices or from their home computer. That's going to be the lowest cost method, both for us as well as for our patients. But one of the things as part of our mHealth team is that we capture is the patient's preferred method of communication, and we try to customize to that. There are some patients that no matter how much I push them are not going to want to use a specific technology. So I think, we could, maybe 10 years from now we'll be there, but there is no ideal world of saying every one of my patients is going to participate in care in the same way. We have, for example, among our chronic care patients, about 50% of our patients, in some practices, especially those that skew to younger patients, upwards of 70% access our patient portal at home. So meaning that they can see all of their results and they can communicate asynchronously in a secure way with all of their providers that they've seen. And we found that has huge, of course, safety benefits. But there are still patients, even those that sign up for it, that simply won't use it. And we found this actually becomes a safety issue when you expect that patients are using something that they have access to, quote unquote, but they don't. We send them an urgent message, but there's a backlog of 5 messages they've never looked at. So it's important for us to know how the patients want to engage us, and maybe that will change over time. But we've really got to we really have to accommodate our patients however they need us to.
Yeah, it's interesting because connected means connected. Doesn't mean wireless or wired. It means connected. So Elliot, is it feasible to overlay a security mechanism, whether it's a computer portal, whether it's an iPad, whether it's an iPhone, where the flow of arguably HIPAA data is going to be kept private and secure?
The short answer is yes, it's feasible. Again, as a voice of customer, I think we have to make this a priority to create those kinds of solutions or tools. The ONC Meaningful Use Stage 2 standards includes a direct portal, which is an email portal, and it includes a federated security certificate framework so that any authenticated user, in principle, should be able to access or send that secure email. Now, that will create an ecosystem of physicians, caregivers, patients who have a security certificate. That same kind of federation of security certificates could be used for many kinds of health applications. Most of the providers, all the wireless companies, they know who has that mobile device. They know who is paying the bill. When you add that to additional things like passwords or user identification, user IDs, or smart systems that automatically engage VPN or other encryption methods so you can control encryption for data in motion, we have the possibility of automating these things in this industry. But that is up to us to tell the community that this is of significant importance. And we need to start piloting this, I think, in some hospitals, if you have control with vendors, or across the ecosystem across many hospitals or health systems. Because what will happen, as you've described, is whoever controls the mobile device management infrastructure will lock everybody else out. And then you've created yet another Tower of Babel, another set of silos, and most physicians have a lot of different responsibilities. Most patients have to see a number of different providers, maybe even cross health systems. So we have to look at this, stand back from it, and come up with a system that is extensible and rational.
One comment that probably not a lot of people are aware, but the new enhanced 911 legislation that came out early this year really calls upon, especially at 700 megahertz, the use of that spectrum for enhanced IP-based 911. So, it's promising folks like Dave who, when he built his wireless infrastructure, the connectivity to the fire life safety part of the community really we see as a bright spot, because arguably the way the legislation was written, the deployment of 700 megahertz in a hospital could actually be a public safety deployment. So, Dave, what's your views on how you work with fire life safety and the synergy we can get from that?
Yeah, we've, onto our engineer DAS, we've put 5 different fire departments, 2 different police departments, and about 4 different ambulance companies. And it's just made it a more seamless system. There's not a dead spot. I can tell you from an ambulance point of view that in other hospitals, their staff are in picking up a patient, transferring them around, and they lose connectivity while they're in the hospital. The fire department doesn't have connectivity when they're in the hospital. When the police department are in the emergency room, a patient goes bad, they're trying to get help, and their radios don't work. So in our facility, we're 100% covered. And back to the ambulance, they prefer on those patients that are on the line that could go to different hospitals, they send them to our hospital because they have connectivity through in and throughout.
Other questions?
I guess the wireless connectivity throughout, and that's a key question, how far it penetrates every operating room, every floor. Is there a standard that the hospitals try to implement, or is it that structure? Is it just simply providing wireless, or is it more technical structure? I may have missed sort of that.
Well, let me answer that one,
Sure.
since that's my job. There is no standard. If you were to go build a building, there's a standard and what's called a master format for heated and cooled air, electricity, plumbing, and that master format sees that utility all the way through construction and operation. But if you were to go to a typical hospital, wireless is an afterthought in most cases. In the cases where it can be designed in, you get some economies of scale. So at the Institute, we have a project to actually generate that base building standard. We affectionately call it MEP, Mechanical Electric Plumbing. We want to add the W to MEP. If you'd be amazed if that's done, how much of the noise, so to speak, comes out of the system. So we have to rally the healthcare delivery organizations. We have to rally the vendor community so that the medical device vendors, imagine if you're an electrical appliance manufacturer, and you did not have the privilege of knowing that the electrical distribution system was assured. It just disrupts the whole business model.
Ed, let me just piggyback on that. Is from my roofs to the basement, to the stairways, to the elevators, inside the operating rooms, inside the CT rooms, inside the MRI, I have 100% guaranteed coverage from all carriers, all wireless, including telemetry, because it was a designed system that was designed as part of the construction of the building and not an afterthought. I shared with Ed, last week I toured a 770,000 square foot brand new building, healthcare tower, $350 million. I walked through the building from roof to basement, and some areas full bars, some areas no bars. And I just shivered to say, how do they run effectively, efficiently in a system that wireless was considered an afterthought.
Chris?
Yes, my name's Rob Campbell. I'm with Volt. We put clinical communication systems in acute care hospitals on smartphones, and I frequently find that hospitals don't even know what they have in terms of their Wi-Fi infrastructure, that the Wi-Fi vendors or the vendors' resellers have improperly installed the systems. We find access points above ceiling tiles, above fire doors. We find access points and controllers stacked on the same channel from floor to floor to floor. What role does the Wi-Fi installer have? Because we frequently have to go in and kind of break the hearts of the hospital and let them know that what they bought from their Wi-Fi organization isn't what they really got. So I'd like maybe your comments on your relationships with your Wi-Fi vendors.
I'll take a first hack at it. First of all, we're going to ask you to sign a petition on your way out that we're going to send to the FCC and say, why is there only a tiny sliver of spectrum dedicated for clinical use, for WMTS, for telemetry? And why is it that we forced our hospitals to go on to the unlicensed band that was never intended to be used the way it's used? Now, reality is reality, and you have to engineer the best Wi-Fi network you can, because Wi-Fi is the only weapon that Paul has to run a better enterprise. And the temptation of a medical device vendor to put a medical-grade device on an unlicensed band is problematic. So I look at the problem of, you better do it the best you can do it, because it's inevitable that people are going to use it, right? You're a good example. You put a clinical system on the unlicensed band. But we have got to fix this problem once and for all by the allocation of spectrum for clinical, medical, life-critical use, and put enough building standard into the deployment of Wi-Fi that Wi-Fi in a hospital, and people disagree, Wi-Fi in a hospital has three uses, right? Consumer, enterprise, and potentially medical grade. And unless you protect the medical grade part of it, then you're playing Russian roulette with that spectrum. So, Paul just opened up arguably one of the most advanced Wi-Fi networks, in the U.S. So,
Well, and our, we used Cisco. Cisco provided our medical grade wireless network, but they really, and they're a leader, but I really think that they don't have the specifications or standards that can predict when you put another type of device on there what's going to happen. And that's why, Ed, when you talk about a reference architecture, we need that for this industry, because we can't take risks, we can't take chances. We're talking about lives. And, for example, when we opened the new hospital, we had problems with our wireless phones that were unanticipated, that the calls, a nurse would answer the call and wouldn't be able. There was a lag of about 10 seconds before they heard anything on, and Cisco didn't predict that, and we had to go back and make some changes in terms of power transmission in the APs in order to accommodate it. But without that reference architecture, we are just playing roulette. We don't know.
Saman, Cable Labs. I just wanted to add to that. Not only do you need to plan ahead for wireless, keep in mind that since we talked about unlicensed spectrum, there are a lot of devices today with Bluetooth and Zigbee and others in the 2.4 gigahertz, ISM band, and they change the characteristics of RF to your point on not being able to know what happens when something's added, think about when everyone walking in the hospital has a device that can interact with your network. Not only does that change your network characteristics from latency to connectivity, but it can also interfere with anything in that band or in the adjacent bands. So there's not only a need to think about it a priori, it would be parochial if you restrict it to just that, and to look at, or maybe look to the standards community to say, you need to do a better job of identifying interference and being able to come up with proactive mechanisms that can either avoid or address it. So.
Yeah, it's a good point. But it isn't just the spectrum and the bands and interference. The use of the bandwidth is shocking. And I've talked to some folks, I won't name the company, in the PACS area, and I asked them at RSNA, well, what kind of data are you sending through these wireless links? 80 gigabytes of streaming data? I mean, and one of the guys in the life care area almost hit him. I mean, how can you do that? Well, because that's what the docs want. So there's to your question about where's the training and the certification, we're not there. We have licensed plumbers, licensed electricians, but whoever wants to put up a wireless network, they may come from the IT department, they may come from facilities, they may come from biomedical engineering, but they haven't really had a huddle, and it's not a system, it's not an engineered system, and there's not a discussion about all the applications that will be on it. It's a pretty irrational state that we're in right now. It's as if you could just keep piling people onto an airplane until maybe the pilot hopes they can take off, kind of. And that's where we're allowing it to be. Again, there's a voice of customers saying, what we need is X, Y, and Z. And the industry has to engineer solutions to meet that.
One of the objectives is to learn from other industries. So since we have a cable labs representative, over the last 25 years, I contend that the cable infrastructure in the U.S. has progressed orders of magnitude past any other infrastructure, to include telecom. And that today, 95% of the population is covered. They have a BYOD problem extraordinaire. They've cracked the code on security, and that their infrastructure is one of the most well-behaved, ecosystem-friendly, open, and its performance is just exponential. So one of the thoughts is, we could learn a lot. Healthcare and all the cable companies come together and fund this non-for-profit to make sure that they have a common architecture across the U.S., which just doesn't exist in the U.S. So, all of these guys, they don't have that type of entity to rely on to protect, them as members of the healthcare community. So, any other questions? Yes, sir.
Hi, my name is Alan Fish. I'm at Aaron Fox, and I do a lot of DAS agreements, so I can feel your pain on the struggles for those. I just wanted to, caution everybody to be careful. I know you're looking to get a lot of really important things out of those agreements, and obviously one of the things you're looking for is to make sure you have the right protections, that if they say they'll do it, what happens if they don't do it, and I know you're working on that. But be careful with the providers also, because a lot of what happens with them is, while you may think you're getting what you want, and maybe you are, maybe you're not, you're also putting up yourself at some risk with some of the things that they put in those agreements, dealing with interference and a lot of other issues. They just want to be really careful about as you do it. The other comment I wanted to make, unrelated to the agreements, but goes to your point, and I'm not here to defend the FCC at all. I'm really, truly not. I think the way the FCC looked at it is in terms of your question of, well, why don't we have the sort of spectrum we looked at? Years ago, there was an FCC with many, many different people. Nobody knew who was going to need what spectrum when it all started out. If they could start over today, it would be very, very different. Then, I've talked to so many people over there, then about how it went over time, where, in other words, it's like, oh my goodness, we need to now do this, we need to now do that. But having said that, I can tell you, and having practiced over there for so many years, the key is to not only make really persuasive arguments, but to really build up the right coalition that you need. I will still remember going to the FCC years ago in a case that we eventually won, and someone said to me over there, fabulous argument, great argument. That is a terrific argument. Boy, is that well analyzed. You will lose. And I said, why? And he said, well, you know, you represent one company. It's a relatively small company. You're going against all these giants. That alone isn't going to be enough. We ended up building a coalition to win because the argument itself wasn't enough. And so that's just one thing I wanted to just, you know, throw out there. Thanks.
Good point. Any other questions?
Just one comment, one question. First comment is, when we talk about RF allocation and RF interference, I think another layer is the credentialing and authentication. We discovered that even though we had handled the RF interference fairly well and had it under control, that as more and more devices came in, all of them were hitting our ACS server, Cisco ACS server, credentialing server, and flooding that. So it was a whole other layer that brought down the entire system that we had to deal with. So I think it's an entire ecosystem that we have to look at, not just RF, but all the way up to how you're accessing the network. The question I have is, how many of you in your organizations have implemented spectrum governance? Certainly you have a lot of service lines below you. Ours is much more fragmented, and it's all based on legacy ownership of Nurse Call and Biomed, et cetera. We haven't really normalized that, but we have brought parties to the table and come up with a structured governance. We're trying to get our local wireless carriers involved, so when they turn up a new tower, we also can we'll know and have some kind of cohesive change management so that we can go in and do our spectrum analysis again. And I just wanted to find out some of the lessons that you guys have had from that.
Don't dive in at once.
It's something that has to be managed, and we manage it through our network infrastructure. And we have a very sharp individual that created standards that nothing goes onto the DAS without going through him, so that he can manage that. But at a big system, that's a challenge. But those are they're standards in place. I'm not sure if they would work at every place.
One thought we had was to create, and I've not even talked to these guys about it, but to create a job position, the chief wireless officer, whose job is to protect and exploit the wireless environment, for a system both inside and out. And if you think about it, Elliot, you don't get the answer. Did the rest of you go through Wireless 101? Most of the IT people haven't. And that's a challenge for the vendors, because most IT shops, they're not wireless experts. And as a result, the vendors kind of have to roll the dice. So we think this is an emerging profession. We think biomed, the intersection, I joke, would I rather take a biomed and turn them into a wireless person, or a wireless person and turn them into a biomed person? Or just start from scratch and grow, an expert. So I think it's a key challenge.
I'd like to add something kind of related to that. One of the things that we've learned is one of the things we're doing at Vanderbilt now is expanding as part of a CMS innovation grant to some of our regional affiliates. And as we've interacted with the IT staff at those different hospitals that are very small town hospitals, you have one person that wears 8 different hats and does different things. And I think that expertise, and it's been something we've been able to help bring them, but as we go to the smaller hospitals, and I think these standards are going to be so critical, and not just at the hospitals, but at the individual physician practices, where they may not have anyone except for maybe the head nurse at there that has a son that knows a little bit about technology, and I'm really not kidding. That's how they manage those things, and I think that having those standards as we go out and achieve true ubiquity, it's going to be critical to be able to teach this and to have examples to show groups that won't have the resources that a big hospital might have.
Excellent point.
Sumant, again, Cable Labs, if I may add to that. One of the reasons that we still hang on to these, as much as we don't always like them, is the convenience that it provides. So the expectation is based on, it's kind of scaled against, the value that it provides. But here you're talking about using it for real life or death scenarios at times, right? So there's a need for standards, but I would also say there's a need for guidelines for such cases. For instance, talking about servers that get clogged, there's a simple solution. If everyone implements like a backup algorithm that's well known, it'll take care of itself. You don't need a supercomputer to handle the million requests. It's been done in other places. So providing those guidelines and educating people about them as they make purchasing decisions so that they can have SLAs and different expectations from what they're getting will go a long way, quite honestly.
I'd like to add a quick comment. I'm that biomedical engineer who became the wireless guy. And we actually learned from a different industry, the auto insurance industry, and why this problem it's not an easy problem to solve. Is like in the auto insurance industry, they started using telematics devices to collect real-time use data, and based on which they're able to give out premiums. A simple challenge that they had was when a car would go under a tunnel, though they had LTE or 3G, the device would stop working and it would lose all the data in between, and then somebody has to restart that device. A simple problem like that is not a wireless problem. It's not a device problem. And it's not probably even an IT problem. So these are challenges because this technology is evolving. And what we did was we actually called up the guys at NASA and asked them, hey, what did you guys do? And they shared a few papers that they published and how they're doing it. And they said that they have something called a housekeeping service. So essentially, whenever things get cut off, the device is programmed so that it collects that information and pre-processes it, so that whenever it does get connected, you're trying to kind of catching up where you left off. And it took them 20 years to get there. And it'll be difficult, even for us, we'll have to go through a number of iterations to solve this problem.
Yeah, our chief medical officer often says, the automobiles of today collect more data on a continuous basis, than most medical devices. So I think, similar to other industries, unless the industry comes together and agrees on that overarching reference architecture, whether it's a standard or not is secondary. Whether it's adopted to use the full procurement power of the healthcare delivery organization is another issue. Until that's done, this is a problem the free market's not going to solve.
And I'm concerned about the cost of the approach that we're taking, because the cost for each hospital and health system to build their own and rip it out and then build it again and rip it out and build it again is incredible. And the secondary cost of replacing devices, replacing management systems, retraining people is enormous. And that's if you don't even consider the liability exposures. And where is the burning platform that we can all get behind and say, this is just a waste of resources that we need to overcome, and move on to more interesting clinical care paradigms like you're talking about, improving the quality and the delivery and the moment of care, and get this stuff in the background where it belongs. It's fun for the first 2 years, 10 years, but enough already. 20 years ago, I was part of a group that helped deal with a new hospital that had been built in Philadelphia without any network wiring at all. And after it was built, they had to retrofit it all in. Sound familiar? We were doing that stuff in hospitals all the time with wireless. And we're not even doing it right. I mean, that's the other, sort of sad part about it.
Okay, I promised you get out early from school here. So if there's no other question, we have one last.
Just a quick question. I'm on the Ekahow. Wireless, to me, means more data. So we have a mobility collecting more and more data from patient-generated data as well. And then inside hospital, we have Wi-Fi-based RTLS or RFID collecting operational data all the time. So you can have all kinds of analytics and business intelligence there. My question is about the big data. So then is that just a buzzword for you guys, or is it a big solution, a big nightmare? Just a quick comment, right?
Dr. Greg, you need to tee that one off. Just a driver.
How hard could it be?
I think that's a great question. And as we start to collect more data, there's not only just the, can we make sense of all the nuances that we might be able to discover new risk profiles and things like that. There is a medical legal risk as we have, and every time we talk to new providers and we say, well, we enable our patients to send this type of data in, 24/7. They say, well, who's going to react to it? I'm not going to react to it at 2 in the morning. And so you need to have policies around that, just at a practical level of what are we going to do with this data. And I think, to me, that goes to the question of not wanting to collect that data in a silo. And it can't be its own standalone system where we say we're going to collect all this data, and then automatically it's going to go to our providers, and they're going to make the right decision at the right time. We need to work together, the different parts of the community, to be able to harness that data and make sense of it so that you can have a digested view to the clinician to make decisions, and then analyze it as well so that we can create a learning system that will evolve. But yeah, I think that we are very reluctant to employ new sources of data collection until we fully understand, at least at the beginning level, how we're going to use that. Because it probably, if we don't think about that ahead of time, it won't serve anybody well.
Did you say automagically?
Automagically.
Have you trademarked that? I'm going to use that.
That's the term that we use for the expectation of some users and some people that somehow things will just be so elegantly used that it's automatic.
I think analytics is the game changer in healthcare. It is what will improve quality and lower cost more dramatically than anything else. Once we get to the point where we can start to use it on a near real-time basis, because today our data warehouses are a day old, a week old, a month old. That isn't going to help us. When I was with Oracle, I visited Mayo, and Ab Bengali, the CIO, told me about a project that he had worked on with the director of pulmonary. Patients that are on respirators for long periods of time, infections from the plastic tubing, and they're ill-equipped to fight the infection, so mortality is high. And they wanted to develop a near real-time analytic solution to that because, we're not going to be reimbursed for these hospital-acquired conditions, and we need to address them, but we need data to do it. So they developed a near real-time solution with about 20 different data feeds coming into a database, and within about a minute and a half of being real-time, they had an analytics program running over the top of it, analyzing, looking for key indicators. When they saw those key indicators, they fed it back to the clinicians via a dashboard. They practically eliminated those types of infections. Now that is what will change the quality of care and lower the cost in this industry. And we've got to get to that point, but we're not there yet. We can't handle the big data yet.
All right. If there are no other questions, let me thank the panel. And thank you.